So I'm Adelina Comas Herrera, and I'm delighted to welcome you to today's webinar of the Global Observatory of Long-Term Care. And today's webinar is hosted by the interest group on pain in long-term care homes. And I'm going to quickly tell you a little bit about the observatory. You may be familiar already, but hopefully will still be useful, and you will also hear about our next webinar. So the Global Observatory of Long-Term Care is a platform for cross-national learning, and the idea is that the learning from the evidence and experiences that we share can help improve and strengthen care systems all over the world, and it's part of the International Long-Term Care Policy Network. And the way you can take part is by joining webinars like today, but you can also be involved by suggesting interest groups that you'd like to run, sharing blog posts, letting us know about your publications, and we are also publishing methods and topic guides. And basically, we are building a database over time where you can find by now 640 experts listed by country, topics, and methods. A lot of publications on long-term care, the videos of webinars, and we also have a database of research projects. And here is the plan for the rest of the term until December. We've got a webinar next, the 14th, on China's integrated medical and social care policy, another one on the 22nd of October on unmet needs, which is the first meeting of the unmet needs, inequalities, and care poverty interest group, one on home-based care provision from the South, focusing on experiences from South Africa and Brazil. We've got one more methodological one on qualitative process tracing in health and social care research, another one from the pain interest group on evidence-based pain management on the 11th of November. We've got one in Spanish on community-based care on the 12th of November. On the 24th, we have the first webinar of a new interest group on innovation in long-term care. 28th of December, we have a day-long celebration of long-term care where we're going to focus on how to change the narrative about long-term care and to see if we can manage to sell better, that is worth investing in better care. And this is part of our celebration of the International Day of Care and Support. And finally, on the 10th of December, one on AI use for qualitative research. And with that, I'm very happy to hand over to Manu, who is going to introduce the interest group and the speakers for today. All yours, Manu.
Thank you, Adelina. Hello and welcome on behalf of Sandra Zwakallen and myself. This pain interest group was built now, I would say 1.5 years, nearly 2 years ago. It was based on our research project from Sandra and myself, Sandra Zwakallen, who was a researcher in the, I would say, past 15 years focusing on pain assessment. And my own research project in long-term care was or is about pain prevalence, pain management, and things like that. So we got in contact and we were thinking about pain. It's such a major issue in long-term care settings, so why not establishing a webinar? So from my side, I will say hello, and I shortly introduce the two speakers of today. On the one hand, we have Yuke Osterman, a colleague and professor. I'm sure I did not pronounce it correctly. A colleague and a professor from Sandra, and she will talk about the neurodegenerative aspects of pain. And on the other hand, we open up the topic a little bit on effective nursing or long-term care research, which can be, of course, applied within the topic of pain in long-term care. And I think we can really learn from both of them. So if there are any questions in between, please use the chats. And then I would say the floor is yours, and welcome and enjoy the webinar.
So this should work, right?
Perfect. Yeah, it
so
works.
Just a brief disclaimer, I fell ill last Sunday and have not really recovered, so my head is a bit woolly. So if I'm going too fast, please put it in the chat. And I'm also not familiar with your background. So I'm a neuropsychologist by training. I'm not sure whether our people actually have a background in a similar topic. But we in neuropsychology, what we actually do is we look at behavior and try to understand the brain in doing so. So we often work with different patient samples, in my case, aging, normal and pathological aging conditions. And that is actually where my interest in pain research started. So if we're looking at the brain, this is quite a complex image, so I will just briefly talk you through it. We know that there is people for years have been looking for like one neural signature of pain, and unfortunately had to conclude there is no such a thing. If we're talking about pain and how it's processed in the brain, we see many different regions involved, and they all have, well, partly at least, unique roles in how pain is processed. And what we know is this is a sort of an overview of the most studied brain regions, I would say. But in general, we have sort of what we call distinct pathways. And one of them, you can see them through the spinal cord entering the brain. You can see my mouse, I hope. Yes, okay, great. So you see a lot of bluish here and a bit of a white general, but also a general pain regions, I could tell, but also more like those involved in how severe is your pain? So how intense is it? What kind of pain is it? And where is it located in your body? On the other hand, what we also know is that we have a lot of brain regions that are also involved in how threatening is the pain? How do you evaluate it? Which sort of cognitive aspects do you sort of relate to the pain you're experiencing? And if we're talking about those regions, what has been for a long time my interest is really this part of that brain system. So this is sort of the frontal part of the brain, the prefrontal cortex. And what we know, it is really crucial for, well, how do you evaluate pain? How do you deal with it? But also in our capacity to inhibit pain. And that goes, as you can see, also via connections with the brainstem here and also back to the spinal cord. So it's really crucial in sort of our higher order evaluation of pain. And what is interesting, and that is my sort of neuropsychological background, we see a lot of these regions are not only involved in pain, but also in different cognitive aspects. And if we're talking about the prefrontal cortex, so that frontal part of the brain, is what we know displays a functioning. And executive function is actually some sort of umbrella term that includes all kind of higher order processes that we do in daily life, like inhibit our behavior, being flexible in how we think and handle in daily life. It allows us to shift between different options. For example, it allows us to plan things, like to plan your route in the supermarket when you're doing your groceries. And as such, it's really fundamental for daily living. It's a very heterogeneous function and also we often use it in our daily lives. And in neuropsychology, what we often do is that we test them with different kinds of neuropsychological tests. I'm not sure whether it's a very familiar one for many, I think. It's a Stroop color word test. And what you actually can see here is that you see the color names are printed in a different ink. And you have to suppress reading the word, which is a very automatic response for most of us. And you instead have to name the ink in which the word is written. So that's really a typical example of a test we use to measure our inhibition performance. So inhibits the automatic response, reading the word here. Another one that's often used is planning. So you see sort of an array with some balls on the left, and your task would be do the thing with the balls on the right image, just a few steps necessary to get the same image, move the green, the red, and the blue ball to sort of copy the image on the left. That's planning. That's our planning ability. Another one, very well known, is we either have to connect numbers in ascending order as fast as possible. I'm sorry. On the other hand, we have to actually switch between numbers and letters in ascending order. And that's really the specific B part here, is really our ability to be mentally flexible. So to switch constantly between those different sets. What I find interesting is if we're thinking about all those executive functions that sort of drive our behavior and at the same time play a sort of strong role in pain inhibition, I had a sort of the question, very, very simple question. Can we actually link those functions to our pain inhibition capacity. So can we see that people who have better executive functions actually have a, for example, a lower pain sensitivity in that sense, so they can actually inhibit their pain. So what I'm sorry, I'm really having for the sniffling. So what we did in a very simple study, we had people without chronic pain across the adult lifespan. So average age was nearly 60, if I remember correctly. And we just asked them, well, put your hand in ice water for as long as possible, right? So a pain tolerance measure, that is. And outside of that ice water bucket, they just performed several executive functions tests. So we had planning, flexibility, inhibition, etc. And then we thought, well, let's see whether we can relate the performance on those tests to how long they actually keep their hand in the ice water. And we expected that for multiple of those executive function measures, we would find that those with better functioning actually could for a longer time hold their hand in the ice water. They could inhibit their pain better. Well, we partly could confirm it. What we actually found is that it's only the case for actually cognitive inhibition. So that Stroop color word test that I just showed you, that's actually the only test that predicted our pain sensitivity. So people who had actually better inhibition ability also hold their hands longer in ice water. And we found similar effects for how intense they rated the pain after they removed their hand from the water and how unpleasant they rated it as well. So it was very unique for that actually cognitive inhibition measure. And it makes a lot of sense because cognitive inhibition of pain sound like similar constructs, but we actually showed that they are indeed related in such a way. I was the first to show this. I was very happy that many studies after that actually confirmed this. So this appears to be quite a robust association. And it's interesting because if we're thinking about aging, what we see is that the inhibition, you see it on the left, but also other measures like working memory, they actually decline with aging. And that is something, and that is what we know from the literature. It is something that occurs relatively early. So aging is not something that starts after we reach the age of 65 or 7. It's sort of a continuous progress that can start as early as the age of 30 already, at least for our speed of processing behavior. And also for inhibition, we know that there is definitely a decline relatively early in life already. So one of the main questions then is, can we actually tell that if people become older and their cognitive inhibition starts to decline, that they actually also show increase in pain they experience? And in order to answer this, we also started to look at people's brains. So if you would see here, you see the image as viewed from the top of the head of someone. And what you actually see is in 60 already, you see it's relatively limited. You see a bit of sort of space occurring here. You have the ventricles here, of course, nicely. But if people get older, you get definitely more atrophy. That's what you actually can see with the enlargement of those spaces here. And what we also know, what is very common in aging, is that you get damage to the white matter. And the white matter is crucial because it forms the connecting tracks between the different brain regions. And if you think about the image that I showed you, that we saw there's a prefrontal cortex, and that is connected to the brainstem, and that is related to our ability to inhibit pain, you can imagine that actually the white matter is crucial in forming that communication between those two brain regions. So what does that mean? Does it mean that people who have that white matter damage may actually have more pain sensitivity, have higher pain reports? That was one of the questions we set out to answer. And we did that in several populations, and one of them was a broad sample of people who visited the memory clinic because of mostly memory complaints. And the people we had actually often had a cognitive impairment, like mild cognitive impairment or different types of dementia. And we simply asked them, how much pain are you suffering from lately? They rated their weekly or monthly pain. And we also had MRI scans, so we could rate the severity of that white matter damage in these patients. And what we actually found, and this is quite a complex image, but I will talk you through it. And if it's unclear, please let me know. We looked at sort of relations between measures of, here you see executive function, but also memory. These are the white matter damage indicators, and this is atrophy of the medial temporal lobes, which is mostly hippocampal atrophy. Of course, a hallmark also of Alzheimer's, just to name some. And what we found is that if people actually have, you see a positive line here with that white matter damage. So if they have more white matter damage, they actually report more pain as well. And for executive function, we also found a similar relationship. You have to perhaps turn it around a bit to your head, but if people have better executive function, they report less pain. So again, we actually could confirm that the executive function that's driven by the prefrontal cortex, but also its underlying connecting structure, the white matter, both are well related to pain, and that if it's more, the integrity is higher, so less white matter damage and better executive function, is that people report less pain. It's also interesting that for memory, found actually an opposite effect. So if memory is better, people report more pain. So that also suggests some sort of unique function of executive functioning here. It may inhibit pain, whereas for memory, it's the opposite. If you have better memory, you might be able to better report the actual pain that you have. That sounds quite logical. I will skip, I think probably because of time, we'll skip this one, but we also found that in vascular dementia, patients who have really a lot of that white matter damage, we also found such a relationship. So the more damage they have, the more pain they report. So that sort of seems to suggest that if we have better executive control, particularly the inhibition part of that, and if we have better white matter integrity, so less damage, we have less pain. But what we did in these studies, and that's crucial to remember, we either had people who did not have a chronic pain condition, and we gave the cold water test to them, or we had a sort of diverse sample of people with and without a chronic pain condition. But how is it if we actually restrict it only to people who actually have chronic pain, like arthritis, for example? We again did that, and we did it in different populations. So this was a study with Alzheimer's dementia patients who all had chronic pain. We looked at how much clinical pain they reported. We looked at their executive function. We looked at their memory. There were also some more emotional aspects measured, like depression. And what we found here is actually totally the reversed. So we found that those with better executive function reported more pain. And that was also, again, for executive function, but it's totally opposite of what we found previously. Also, when we tested individuals who had, well, they had no cognitive impairment, but they were living in residential care. Again, we found the same. If you only include the individuals who actually have a chronic pain condition, we find an opposite association. So those with better executive function actually report more pain. And so that is a very sort of, well, tricky or a very challenging finding. So how can we actually merge them together? Well, it is, I would say, still ongoing research because it is very tricky. But what I think what is crucial to remember is that if you look at executive function and specifically that cognitive inhibition, that actually shows a unique relationship, as it seems. Better cognitive inhibition allows you perhaps to better inhibit your pain as well. And we also see that in that white matter connectivity underlying that. And I have to I admit to you, because I took a look at that those associations in our study, where we had just a wide area of individuals, were strongest in those who did not have a chronic pain condition. So that implies that if people actually have better executive control, they may have lower, just general spontaneous pain complaints. That could be a very well a suggestion. And we know that, of course, if we look at our body, if we look at our brain, there's a constant influx of information and a constant natural suppression of top-down processes, right? Like those from the prefrontal cortex. It could be that the executive control, that white matter integrity, is crucially related in that. There's some support for that, of course. We know that severe damage also related to white matter tracts, for example, after stroke, can actually cause spontaneous pain as well. So there is some sort of natural pain inhibition process in our brain in that sense that regulates just incoming information constantly and interprets it rightly. The crucial question, of course, here, is it really just for pain that we find this, or can we also find it for other complaints, like other emotional factors, for example, depressive symptoms? That's something we need to study further. However, if we only select the people who actually have chronic pain and who have a chronic pain condition, we do find the opposite effect. So those who have better executive control, it's not specific to inhibition in this case, it's just executive control in general. They report more pain. And it might be that that executive control allows them to evaluate the incoming sensory information. It allows them to reflect on it. It might be that they are more aware of what they're experiencing. It might be that they have an intention to report more, perhaps, because they actually can reflect also on what they're experiencing. It's very tricky in this case. I don't have the answer yet of how we can explain it, but we do know, if you look at the brain and also in all those diverse executive functions, that we do see different regions within the frontal cortex associated with these different functions. So it might be, on the one hand, that we have some functions that are relevant for awareness and our ability to reflect on pain. And there's other functions that actually play a crucial role in inhibiting that pain. So that is a question for future research that I have. Yeah, so we're not done yet, but it's tricky. But I think my main question for you is that, or my main message actually, is that if there is cognitive decline and there is specifically executive function decline, I think you should be very much aware that the people may underreport on pain. We know that, of course, for many times in those with cognitive impairment for many years already. But I think specifically for executive function, there we find a lot of evidence that it plays really a crucial role in our pain report. So those with worse inhibition can perhaps better or less well inhibit our pain. And on the other hand, if there is arthrosis or arthritis or whatever kind of chronic pain condition, if cognitive function declines, specifically executive control, people may underreport on their pain as well. So in that sense, a sort of final message, I think. Am I okay with the time now? I hope I am, because this was my final slide for you.
Thank you very much. There are already a few questions in the chat. So during you were speaking, the one was, I think it was with the 19 participants, Margaret, maybe you can go on with that. Your two questions, please, to explain what you mean.
Perhaps not.
I've just turned off the
Sorry,
ability to unmute.
Yeah, I couldn't unmute. Yeah. No, I mean, really interesting presentation. Thank you so much for that, Jukka. But I'm just wondering, what were the numbers like for this data, and how did you actually select the people to participate? How representative are they sort of populations?
Yeah,
were there any other factors that might have skewed it? Because obviously old is a big data set, isn't it, from 60 to 110 or however?
Yeah, so that's a good question. I have to admit that of course the numbers were in general relatively low. And it's also partly because it's very tricky to get the people. So for example, this one with that vascular dementia, those were people living in residential care facilities, but they all had a probable vascular dementia diagnosis. So that includes also a neuropsychological evaluation, evidence of vascular damage. And in this case, they all had subcortical or white matter damage that was obvious. But they are, by this I don't know by head, but in general, I think the groups were relatively small. This one actually was large. I think we had, I have to look it up, but it was over 100 patients in this.
Yeah, that was the one that I was particularly interested in, because that's quite very, very stratified, isn't it? Yes.
Yeah, and it is a heterogeneous population, right? So we did not have the numbers to really split on type of diagnosis. Most had some MCI or Alzheimer related pathology. But what I have Right now, I have still to analyze it. We also have now an adult lifespan sample again, where we also ask for just pain at this moment, also over the last month. There we have 300 people, well, slightly less, between 18 and 80. And for pain, it seems that we again find such an association with that white matter integrity and the pain report. So it is quite robust in that sense. I also did this in just normal aging individuals. That is the one here. There we also had 150, no, 160 people perhaps. No, it was less. It wasn't, no. But at least a couple of dozen people in that. Also, again, we found that those with more white matter damage actually report more pain. So that for me, that appears to be a robust finding. It's really the question, is it really a pain-specific something, or do we see like a general emotional, I don't know, overexpression? Because it's for some, yeah, I think there might be a bit similar results, for example, for depressive symptoms being reported, but they're not that strong. But I really have to look in it further, and that really requires a lot of people to really be able to make a, yeah, really robust, I don't know, to have some sort of conclusion there. So it's sometimes limited the number of people, yeah. Definitely good to know. Yeah.
So we have another question. Janine, maybe you can go on.
Yeah,
Yes,
and
sorry.
yeah, this
Yes.
image is the one from the most upper reference, so that's good to know. The Madriaga.
Sorry, yes, my question's around what is happening with that pain. Is in my experience, all too often especially in long-term residential care, pain is often it's reflected in how somebody might be behaving, and that is often misdiagnosed as being a symptom of dementia and not necessarily as a symptom of pain. And so often the prescribing route from that is actually quite an inappropriate prescribing route. I'm just wondering if that's something that's been taken into consideration as to what is happening when people are being identified as potentially having pain.
Oh, that's a very good question. I have to admit that is a bit beyond my expertise, but it's of course a major question that you see, for example, like restless behavior or agitation, right, as signs of dementia. I know that there have been studies showing that if you treat people on, like, for example, with paracetamol, that also those behavioral indicators may actually decline as well. That is what I know. But how like the clinical guidelines are on that I have to admit I don't know. It's a very good question.
Okay, thank you. Thanks.
Perhaps the other speaker knows about that.
Not about that. I have one more question, because I think this is really interesting. You said when the executive function is better, then they also report higher pain, a higher frequency or higher pain intensity. And I was thinking, have you ever thought about the first thing is not only including people with dementia, with diagnosed dementia, but just people with cognitive impairment through the mini-mental state? And what about people that are not able to speak anymore due to their cognitive impairment? Do they also include that? Because I had the feeling they're missing here somehow. So how to your brain pictures with non-verbal assessment, proxy assessments.
Yeah, so we had it's a good question. So in this study, actually, we had a wide range of individuals, from those with only subjective complaints, a few, to those with mild impairment, to those with dementia. They are all in, but we just examined them in a total way because of the limited power otherwise. So I have, in that sense, well, gone through like normal aging towards dementia. It's, yeah, so people with only cognitive impairments, yeah, so those with MCI actually have that. In general, I think it is not dependent on the sample, but it's a very, very hesitant conclusion I would have to give. So I know that also in those with, for example, frontotemporal dementia, they especially those that have really frontal dysfunction or executive function problems, You can also see that decline in the pain report, but also as in relation to experimental pain. So it appears to be quite a sort of association you can see across different samples. We have in one study, I have not shown it here, we have looked at like the facial expressions of people who got experimental pressure pain in aging. And now I have to very quickly sneak again. We did find again also with the facial expression in relation with executive function. So that would also be, would imply a relationship with non-verbal communication as well. But I have to look up because it's my own study, but it was some time ago. I don't know. I think we found again the relation of those with better executive function might actually responded more. But I would have to look it up, to be honest. It's horrible. I don't know even my own study.
Yeah, that's fine.
But we have looked at it, and it's I think in line with one of the two it was in line with one of the two findings here, but I have to look up the direction again because I have forgotten.
But maybe you can send us the link of the article if something is published, and we can send it to the participants here. So if they want to go into that a little bit more deep, then they can look it up. That would be great.
Yeah,
so
I can definitely do that.
Yeah, we have one more statement, Janine. It's about pain assessment. The pain aid, it's very useful. Currently, I think next year we will make one more webinar about pain assessment instruments. So I would invite Janine that we go into deep in the next webinar next year, because there is an ongoing discussion what to use and things like that. So I would postpone this statement for the second webinar next year. So then I would like to say hello, Claire Goodman. We know each other, I think, from another network I have with Brazilian, UK, Netherlands. Did I miss a nationality? I have no idea where we first met. And she will now tell us a little bit more broad about how can we as a researcher or even as practitioners improve research in care homes. How can we help researchers on the one hand from the practice, and we as a researchers to make care home research really effective? And Claire, do you want me to share now your slides?
Yes, please, just because we spent 10 minutes before.
To do that because we've tried it, it doesn't work, so I'm going to do that now. So Claire, the floor is yours.
Thank you so much. It's not on presentation mode yet.
Oh yeah, no.
Yes, so there we go. So this is about the Dacha study, which has just finished in the last year, ran for 4.5 years. And really what I'm bringing here is some reflections on, it's not just what we're trying to do, but it's how we do it affects the outcomes. So if you could go to the next slide, please, Manny. And this is about data. The Dacha study was interested on all the different sources of information there are about older people in long-term care. And it was asking, can you bring all this information together to stop the duplication and fragmentation? So you can try the next slide. So the first aim, which is really what I'm talking about today, is to establish what kind of data needs to be in place to support research, service development, and uptake of innovation. And if you just click again, Manu, so that's what I'm going to talk about. But then we took that further to develop a minimum data set that everybody who worked in, with, and for care homes could access and use. So you weren't constantly asking for the same information, particularly from care homes. So in the next slide, what you can see is there are a lot of publications. It's a 4.5-year study, a large team. So anything I'm talking about now is really just an overview, and I'll give you the references at the end of the presentation for them. So next slide, please. So what do we do to actually enable research in and with care homes. And early in the study, we did 2 evidence reviews. And the first one was led by Guy Perrier, looking about whether interventions fail for reasons other than the intervention's effectiveness. And the second one was looking at outcome measures. And I think just listening to the previous conversation, I'm really glad to be hearing you're going to be looking at that, because I think that review throws up a lot of questions. So we can go to the next slide, please. So essentially, Guy was asking, he was reflecting that many care home trials have neutral or worse negative findings. And he thought it's really unclear if neutral findings were due to the intervention itself, or was it a consequence of how it was introduced into the care home, or a consequence that the measurement tools didn't really fit care home settings. And these questions came out of him being involved in several trials. So this was a systematic review of 33 process evaluations linked to 32 trials. And there were 2 big findings. What they found was that obviously all these trials had signed people up, people could see the importance and value of the study. But as they progressed, you could see there was what he calls procedural drift, that people lost engagement, staff forgot what it was about. And so to the effect that actually the intervention wasn't even getting delivered sometimes because it didn't fit or people didn't remember why. But the more positive reason was, he said, but where the studies were able to introduce participatory action and learning with the staff, so there was a sense of collective endeavour, then you saw the intervention being sustained and there was more fidelity. So those are the big headline messages, and as I see, you can see the paper later. And out of that, we developed 2 resources, one for research teams and one for care home staff. So can we have the next slide? So you cannot read this, but this is a leaflet, which again, you can download. But essentially what it is suggesting is that anybody going into a care home to do, in this case, intervention research, but I think it probably does apply, you need to be systematic. You need to work through all the possible things that we think the evidence suggests help or hinder delivering a study. And so it's like a checklist, so that you wouldn't go ahead with a study if you began to realize that even with a lot of enthusiasm, people really didn't have the capacity to take part. And I would guess that most people listening will have thought of these things, but what this is trying to do is just, can you just work it through and be systematic? So that's something for research teams. And I think we would say it helps to have done this pre-work, which is more than just getting everybody consented and on board. And then Karen Spilsbury, the next slide, took some of this work and working with the Leeds team, developed something for care homes, because care homes themselves are not necessarily particularly research knowledgeable. So if they say yes to a study, do they know what they're saying yes to? And are they sometimes surprised by how much they are expected to do for the research team? And so again, this was a piece of paper written in a professional journal for care staff. And these were the sort of, again, mimicking the questions. And the next slide. Going on to help a decision-making pathway for the care homes and evening up what can be a bit of a power imbalance of where the researchers know what they want to do, and they're just saying, oh, you know, if you're happy to do it, we'll work with you. And when I was thinking about pain, I remembered being in a workshop with a care home manager, and she was just saying, look, I'm really interested in this case, it was palliative care. So obviously pain is a big element of that. But my priority is to understand how to release clinical staff from the tyranny of the medication round. I have expert staff spending a lot of time with medication when I would like to release them to do pain assessment for other things. So it's also about figuring out how the priorities align. So that was one thing. Next slide, please. The second review was looking at outcome measures, and this was Jenny Burton from Glasgow and Sarah Kelly started this work, and we were interested to know what in research are the outcome measures used for care home populations. Looked at intervention studies, 436 papers, a massive piece of work. And reviewing all of that, identified 732 outcome measures being used, which is not surprising. These were all studies about lots of different topics. But more importantly, only 14 of those outcome measures were being used in 20 or more studies. So that when you think about a care home population, you're beginning to think, well, maybe there could be a bit more standardization when we think about things that any study might want to know. But when they did the detailed data extraction, what became very clear was that all the outcomes tended to be health dominated, and they'd not been developed for care homes. They had been developed in hospital and clinical settings. They typically measured functional status, mood and behavior, and medication. So all core interests, but with lots of different ways of measuring it. And the fifth of the research studies used information gathered routinely by the care home. So they were very reliant on the information they could get, which also, of course, was not standardized. And I did then go back into the study and looked at pain. And they identified that there were 5 studies in these 436 papers that had looked at pain and used the pain inventory. And there were a further 5 studies that had also used the pain assessment in advanced dementia. So in the next slide. Oh, next slide, no?
One moment. It's not working. Let's see if this is working. Yeah, sorry.
So what they recommended from these reviews was that care homes need to work together to measure what matters to both. That international agreement, and I suppose this speaks to Adelina's work and what we're talking about here, about the best outcome measures, say for function or medication and so on, would be really helpful. And we need measures that can show changes over time in a care home population who decline in a very different way to hospital populations. And there was a dearth of studies that looked at quality of life, which is actually really important in long-term care. And we need to recognize if we keep using loads and loads of different outcome measures, that's really wasteful because you can't actually then compare and build your work. And there's a really big case for developing core outcome sets for long-term care settings. And people are doing it, but I think this would be something maybe to talk about later. Next slide, please. So efficient use of data. So these were 2 studies within the Dutch study, one that developed a trial archive, and I'm going to talk about that, and another that surveyed the data that care homes already routinely collect. So this is both information we already have, but is possibly not being used well for research. So to sort of reduce waste, more efficient, and actually not asking care homes to do more data capture if you can avoid it. So the next slide, please. So this, Lisa Irvin led this work and was very much something that came out of having worked as a health economist on a lot of trials. And so her goal was to repurpose high quality anonymized care home trial data so that that data from multiple trials, which in a lot of trials, even though they're looking at different questions, gather very similar information about residents' characteristics, about their symptoms, about their medication, about their pathway into a care home. All that kind of information is quite generic. And pool it to then be able to do secondary data analysis. So invited different leaders of trials to contribute their data. And so we now have an archive of over 6,000 individual participant data with option to add more and open to more trials. So for studies like the earlier conversation about the size of your testing and the powering, suddenly you actually can ask many more questions. And there is the website to have a look at it. So it's the first time an archive has been developed based on a setting, a care home. There are these archives for like stroke research or hypertension research. And already somebody is interrogating the database to look at quality of life, standardized use of quality of life measures. And Lisa is just about to write up, she followed on from this work, asking people to say, well, what would be good questions suitable for secondary data analysis? And she'll be publishing that by the end of the year. So this is a really exciting development in terms of you don't have to go anywhere near a care home to have really good care home data. So we're hoping that that's going to go forward. There's been a lot of interest in that, but it's a lot of work to do in the pooling and the standardizing. Next slide, please. So this was a national survey that we did as part of the DACHA study. I think tapping into that recognition early on that we don't actually know what routine data care homes collect and how much of that would be something that you would want to link your research work with. And so Barbara Hanratty from Newcastle led this work, and it happened during the pandemic. So a phenomenal response from the care home sector, who were really under pressure. So these were individual care homes, but because they were all members of chains, their responses reflected about 5,000 care homes and how they approach data collection. So aggregate data, individual data, staff and staffing information. And we also asked someone, where do you store your data? How much is digital and how much is paper? So if you could go to the next slide, what we found was a huge range of data was already collected, and fairly common use of clinical and health tools that have been validated, including care homes that don't have on-site clinicians. We found very few measures of quality of life. There is a recurring issue here that each of these studies highlighted, but we also showed that these care homes already had multiple purposes for the data, but they were experiencing data storage and sharing challenges. So whilst they had all this data and you could immediately see the potential, there were real concerns about how they should be or could be sharing that outside of their boundaries, which is something that DACHA went on to tackle. And I had a look again at what this part of the work looked at pain. So next thing. So for those, I think the pain ed scale was mentioned. So 62% of the people that replied were already using the Abbey pain scale for routine care. Faces pain scale 15%, and then you can see pain ed for 36%. So I think that shows that there is an awareness of the value of using standardized or methods for pain, but actually not coordinated. So again, just reiterating, this isn't something we have to start from a blank page. There's a lot to work with here. Okay, thank you. Next slide. Right, meaningful engagement. So this is the last bit I'm going to talk about, where the DACHA team was 14 people. We'd come together through an interest in care homes. And so we all brought lots of different experiences of trying to, if you like, even up the unequal partnership between people in care homes and researchers, and particularly residents who often have other people talking on their behalf, be that staff or family members. And so I'm just going to summarize how we tried to tackle that in the DACHA study and what happened. So next slide, please. So our public involvement, where we were just trying to involve people at every element of the study, but also influencing the study. So we had a panel of family members, care home staff, including junior staff. So staff who were had very little experience of just talking in meetings, even to talk about what we were trying to do. We were interested, and we counted them like residents in the fact that they had the lived experience of trying to collect information, record it, and how they used it. And so they would meet 17 times. We had a national expert consultation group that brought together stakeholders of people who work in, with, and for care homes, including and family carers. And that group, we fed early findings and said, what do you think? Do you think you could use this? And in the end, we ended up focusing on different ways of measuring quality of life in that to come up with the standardized measures we used. To achieve that, we had a public involvement team funded. So the DACHA study was funded for £2.3 million. And we had two senior researchers coordinating, and we had a senior research assistant who coordinated all this work. So I suppose the big message for effective research is you need the money to be able to do this kind of work, and core research team. And then we had our usual study steering committee that also had public representation. But the one thing we did with residents, next slide, please, was in our proposal, we said we were going to have resident panels in the care homes, but 2 months after DACHA started, the pandemic hit. So obviously no researcher was able to go into the care homes. And we already knew that there were a lot of challenges in getting residents' opinions or views about research. But it was also an opportunity that came up because we worked with the National Activity Providers Association, which is a professional body for care home staff who either that is their job in the care home to run activities and provide sort of a social stimulation and engagement in the care home, or it's part of their job. And so because we couldn't go into the care homes, we worked with some activity providers to run activity sessions about the DACHA study. So in effect, you were saying, would you like to do flower arranging today, or would you like to talk about the DACHA study? And so we worked with them to have resources and prompts that people with cognitive loss could relate to, and to explain the study. And so over this time, there were 208 residents contacts, and residents were able to talk about what mattered to them, and it's particularly how the information would be used. And what was interesting was they came out like they said, well, of course I don't mind the doctor seeing my care home information. It makes sense to put that together, but I'm not sure I want my family seeing this information about me. And nobody had really had those kind of conversations about the ownership of data at that level and at that personal level. And they were highlighting that this really needs to be tackled in the study. It also changed care home practices. That was a sort of byproduct because staff weren't used to talking about how do we work. It also was quite difficult because sometimes things came up that were very difficult to hear, but it did challenge some care home thinking about what they were doing and began to help people think about research as a whole community of staff, which goes a little bit back to what Guy was saying about it has to be a collective endeavor. So next slide, please. So this is really a summary of what the DACHA study did, and there's the website, and we have got all the resources there and trying to update them. So we provided guidance on how to engage with care homes, outcome measurement and information. We haven't said how to do it, but we said these are some things you really need to think through. We've got new methods and resources. We have the bit I haven't been able to talk about. What we were able to do was link the care home data using all these different data sources for each resident between health, care home, and their social care contractors to deliver a minimum data set that people could access. And we worked with 2 software providers using digital care records, and we could do a whole webinar on the governance of data moving outside of an organization. And we did it in 3 regions and showed it was feasible and useful and usable. And some of that work is being taken forward. We have the next slide, please. And it was a huge team. And I'm looking at this list, and this is an out-of-date list. So please go on to the website, because there are, to my shame, there are people's, I obviously used an old slide when I was doing this presentation. So, but everything you've heard is my view and not that of the funder. Thank you. That's it.
So thank you, Claire, for the presentation. I'm going to stop sharing. Yes, thank you very much. So do we have already questions in the chat? There are 3 new. Oh yeah, there's the article about facial expressions is already in the chat. Thank you, Yuki. Yeah, we're gonna describe myself. Care homes to release tablet burden from residents and staff. So Joshua, is there a specific question behind your statement in the chat?
No, it was just in response to the previous speaker's comment that she was making about burden of staff and pain assessments and things like that with tablets. So yeah.
So I mean, that's
it's
a really good example, isn't it, of where if the research incorporates anything around deprescribing or different ways of administration, that it would become a more embedded priority.
Absolutely.
Yeah, there's a lot of studies in this area don't look at the method of how medicines are given, they just focus on the issue. So yeah, I think it's a really good example of where if we are genuinely helping people work better, then obviously the research is more valid.
I would have one question. You were talking about this minimum data set. These are data you get from the organization or organizations already collect them, and you build more or less a minimum data set. Is there anything about pain, and I'm not talking about medication, pain frequency, severity? Is there something in?
So the biggest challenge of doing a minimum data set is the minute you do it, everybody wants the data they're interested in included. And we didn't include data on the day-to-day experience of pain, but we did include, the standardized measures. And when we did the consultations, the feedback we got was there wasn't enough about palliative care. And I think that was, so what we did was we used nothing went into the minimum data set that didn't have an evidence base, if that makes sense. So we used what the care homes used if there was an evidence base, like the Bartel and those kind of measures. But we added some around delirium, which people weren't using, quality of life measures we added. I'm trying to think, there were a few where there were clear gaps that it wasn't in the GP, general practitioner. We linked GP data, so that's where the medication data came from. We linked hospital episode data and urgent and emergency. So it was to try and not, and as I said, the consultation said you really haven't tackled palliative care, and this is a big issue for this population. So that would obviously encompass pain management and symptom assessment. So we, yes, but the goal was to have so it doesn't, obviously the care homes were collecting all that information for day-to-day care, but in terms of having something that people could all look at and be the basis for a conversation without requiring a separate data generation activity. And it did seem to work, the care homes that took part, but Rachel Carroll is taking some of that work forward with Dash to ask, well, how can staff interpret this? We ran out of time on developing a dashboard and feedback. And the reason we ran out of time was because it was 6 months of arguing about governance. No, having constructive conversations about data governance, which have to be done, but we thought we'd ticked every box and then discovered we hadn't. So or the rules changed is probably the better thing, but we
So I think we are now closing the session. So thank you very much, both speakers. Excellent presentation. What I wrote down is, for me, is the one thing about how to implement things, how to implement pain, or implement interventions in the topic of pain might be a struggle. And now from your presentation, Yoki, it's more about
one side correct.
It's more about engaging people with cognitive impairment to also be part of such experimental. Because for me as a nursing scientist, I'm a nursing scientist, not thinking on the broader scope of, or on the broader disciplines, what is there. So I think this is one big point. And what is a missing point, and I think we can also go into that in maybe in the next webinar, is about these cure outcome sets. We had that already last year, one about pain outcomes, how to measure and things like that. But this might be something, because Claire said there are a lot of missing, specifically for the care home setting, long-term care setting. So I think these are just 3 thoughts I have now through these presentations and the discussion now that we will try to incorporate into the next webinars next years. So Adelina, you want to close, say something?
I just want to thank you for yet another very engaging and very interesting webinar. I learned a lot because this is not my area coming from economics, but it is fascinating, and it is clearly something that we need to make sure there's more awareness of. Thank you. That was a very, very good webinar.
So thank you very much from my side. Thank you, Claire. Thank you, Yuki. And the next, thank you, Nas. Yeah, truly, absolutely, truly. And the next one on pain is on the 11th of November. And then we are talking about evidence-based pain management. So I hope to see you there, and have a nice morning. I don't know, lunchtime, whatever, evening. Have a nice day and see you soon. Thank you. Bye.
Thank you very much.